Hi class. In chapter 3, we are going to see how how economics and the economics framework can help us analyze medical care markets. We have already seen some of the tools that we're going to use, so we're going to use some of those tools, but now we're going to combine them, we're going to use them at the same time, and we're going to see how economics can help us analyze the markets. And we start with a battle of the titans, a bilateral monopoly. So what would happen if a monopoly and a monopsony face off? So remember, a monopoly is a single supplier, a monopsony is a single buyer. So for example, again, it would be, for example, a hospital that is the only hospital in the area and they're the only ones that hire nurses and doctors. They are the ones buying, right? So that would be a monopsony, or it could be the hospital as a monopoly if it's offering, if it's the only place where you can get treatment. So we're going to look at some examples. We're going to see how that works. But there you have it. You have the battle of the titans of a single buyer and a single buyer and a single producer going at each other. So clearly, each of them is going to exercise the market power that they have. They're going to flex muscle, right? And the supplier will want to supply at whatever price, whatever quantity, and the consumer, the buyer, will want to buy at whatever price and as much quantity as he wants at that price. Both of them are going to follow the rules of economics. They're both going to maximize profit. They're both going to try to get to that marginal cost equals marginal revenue. So we have it here, for example, right? We're looking at point A. So here, the marginal cost of the supplier equals the marginal revenue. So the supplier will want to supply Q2 amounts at a price of P2. Remember how we do this in chapter 2, we saw how we do this analysis. Go back if you need to review that. But that's where the supplier will want to be, the monopoly, right? Now, what happens with the monopsony? The monopsony is going to use the exact same strategy. They're going to find that point where the marginal cost equals the marginal revenue, and for them, it's going to be point B. That's the marginal cost for the buyer, for the monopsony, and that would be the marginal value for them. It would be the demand curve in this case. So they will want to purchase Q1 at P3. So as you can see already, right, the buyer wants to pay a lower price, P3. The monopoly wants to charge a higher price, P2. The monopsony, the buyer, wants Q1, but the supplier, the monopoly, only wants to supply so little. So what happens in this case? How can we find a solution? Well, in this case, they will both exercise their power, they will negotiate, and the final outcome will fall somewhere in between Q2 and Q1. And so where would that fall? Well, it depends. It will depend on the elasticities of these curves. You could say, oh, it will fall right in the middle. Well, that would be in the perfect world, but it's somewhere in the middle of the two. Maybe not exactly in the middle, but somewhere between them. So where do we see this in healthcare? I already mentioned the case of the hospitals, but for example, you also have the case of certain providers and Medicare or insurance carriers. When you think about a hospital and how they charge the government. In case of Medicare, they charge certain fees for certain procedures. Well, in this case, you could say that the government, Medicare, is the monopsony. They are the single buyers of healthcare for retirees, for the elderly. So the hospitals, when they are negotiating the fees, they're really facing a titan. They're facing a very, very strong buyer, the government. Is it a monopsony? We could argue about that, but let's just for the sake of this conversation, let's just assume that they are the only buyers for the elderly, and also insurance carriers. We have, here in Massachusetts, we have multiple carriers, but I'm sure in other areas there are not as many carriers, or maybe there's one carrier that has far more market share than the others, so that one could almost act as a monopsony because the market power is so strong. It could be seen as really the only one. So we do see this in healthcare. So that's one case of how economics helps us understand medical markets. But should they exist? Should we have medical care markets, or should we just have a system where there are no markets, where there's no direction, where there is nothing? Just whatever happens. You don't pay for your care. The government pays for that care, and nobody looks at any of these things, and we don't care. Would that be a better system? I disagree. I think we need controls, and we need to understand the market. So we use economics to assess healthcare, but of course we must assume, in order to use economics, we must assume that all the participants are trying to be effective. They're trying to be optimal. They're trying to get the most they can for what they have, whatever that is, whatever they're offering in exchange. So we assume that, and I do think is true. Now, there are some significant differences in the healthcare market when compared to other markets. I'm not saying that these are not present in other markets. They are present in other markets, but it is true that in the healthcare market, it's kind of like we have all of the possible issues. We have them. Healthcare is unpredictable. I may or may not disagree with that up to a point. It is predictable in some aspects, but in others it's not predictable. You don't really know when certain person is going to need a surgery, but we do know, when we look at the entire population, we do know how many people approximately are going to have appendectomy surgery next year. We know that because we have that data. We can predict it. So there's certain predictability. But in general, there are a lot of aspects of it that are unpredictable. Asymmetric information. Yes, I agree, it does exist. By the way, you'll see through this chapter and many other chapters that I don't always agree with the author on everything. But that's the beauty of it, that we can discuss that, and we can debate. There is asymmetric information. The hospital, the doctors, they always know more than you about your health. And that's probably a good thing in some cases, but in other cases, maybe not a good thing, because maybe the patient doesn't have all the information that the individual should have. Trust. We can look at that in different ways, but we don't trust all the participants exactly the same way. I think we do all trust our PCP, our doctor. I think we do. We believe, no matter what they say, we kind of believe it. But maybe we don't believe other providers. Maybe we don't believe the insurance companies. Maybe we don't believe pharmaceuticals. So there's some type of there's a situation there. The trust is not the same, and when it comes to doctors, this trust it's so incredibly strong that the patients end up doing things not even thinking about them, right? They just do them because the doctor said so. Is that a good thing? Maybe medically it's a good thing, but in economics we have a problem with that. Barriers to entry. This is very true. Not exclusive to the medical market, to healthcare, but definitely there are very, very high barriers to entry, and you start just by the fact that to be a professional, you need to have a degree, you need to be licensed, you need to be et cetera, right? You can't just you can't just act as a doctor tomorrow just because you watch a couple videos on YouTube, right? You can't do that. But that's also true about many professions, right? To be a plumber, even if you know how to do plumbing, you need some license, you need to be insured, that kind of thing. But the barriers to entry in this industry are mighty big. They're very, very, very big. And then we have payment practices. Usually when economics looks at markets, the payment practice is not something that we look at, because we assume that the buyer pays and the supplier receives, and that's the end of it. Not much to think about that. However, that is not true in healthcare. Most people don't pay for their healthcare, right? Either the government or the insurance company pays on behalf of the patient. That's a problem for economics. But I mean, a problem that we love to talk about and research. So ultimately, should we have markets? Should we allow people to act as economic agents, or should we just leave it to the government to decide what, when, who, where, and etc.? So it's up to whatever the government wants me to do, I'll do it. Whatever they want to pay, they'll pay, and that's how much the hospitals get. We'll see about that. I'm sure you have an opinion. I definitely have an opinion. That's why I like economics, because economics tells me no. But that doesn't mean that there's no room for the government. I do believe there's room for the government, but that's what I'm going to try to convince you for the next few months, is that markets are necessary, and just having all the decisions centralized in one place is probably not a good idea. And of course, we do have samples around the world of that. There are many countries that organize their healthcare around this idea of centralized decision making. And for those of you that do believe that the government should just govern the entire healthcare market, and that's that, well, here's some of the reasons that some of the arguments that you could make. The medicine is too complicated for the markets to take care of that. Okay, it's too difficult to understand, and we the people are not educated enough to understand. And whatever the doctors say, that's it. They are the gods in this system. Medical good is a social good. That I definitely don't believe. We'll talk about that later. There are certain externalities. We'll talk about externalities, what they mean, how to deal with them. So that means that there are forces beyond what the market captures that should be taken into account, that are not being taken into account by the market. And that's why you shouldn't have markets govern the healthcare market. And the idea that you have to pay for your own care is morally just not right. Health care should be free for everyone, because that's something that you are born. That's a right that you're born with, and that's that, and no one can take that away from you. Maybe that is your belief, which of course you have the right to believe that. But those are some of the arguments that you can make. Now, those like me who oppose that idea, our system has remained mainly private, mainly market-oriented, and it has worked quite well, even though some people may disagree. I think it works quite well. So I do believe in the markets. I don't trust I don't trust. It's not that I don't trust the government, it's that I don't trust a centralized decision-making process. I don't trust the fact that someone is making all the decisions. That's the problem. It's not, again, it's not that the government, I don't have a problem with the government, is the fact that someone is making those decisions for me and I have no say. That's my problem. And that's a problem for economists. And ultimately, the biggest problem we have here is, and this is why we have a debate, is the cost. If there was no cost, there wouldn't be a debate. But there is a cost in hospital care, physicians, and prescription drugs, and other types of spending in healthcare is just very, very large, and it keeps growing, and there doesn't seem to be an end to it. And that's why there's a debate. And if you look at these numbers, which are obviously from your textbook, you can see where all the spending is going, and you can compare where we were in the 1960s to where we are today, right? So I'm looking at, so personal health care will be the addition, it will be the sum of everything above it. And as you can see, we used to spend $23.3 billion in the 60s, and we're now at 2.3 thousand, so 2,360 thousand billion in the year 2012. Imagine what that would be in today's today. It it is much, much, much higher. I actually don't remember the number right now, but it is much, much higher. I'm sure that number will happen. Will pop later, and we'll talk about it. But more importantly, you're thinking, well, but what does that mean, inflation? Well, this is the number that you need to look at, and that's the number that concerns me the most. In the 1960s, we were dedicating 5.2% of our GDP, of our gross domestic product, to healthcare. 5.2. Today, it's at 17.2. And I believe, I'm sorry, not today, but in 2012, it's 17.2. And I believe today is at 19 something, almost 20%. So this is a problem. We're spending too much in healthcare. Oops, sorry. And there are other issues. Not cost is an issue, but there are other issues. We have the issue of access to care. We still have, and this number has dramatically decreased in the past few years thanks to healthcare reform during the Obama administration. We still have about 8 to 9% of Americans are still they still live without health insurance, and that number is clearly very high. It's much lower than it used to be, but it is very high, and that is a problem. Access to care is a problem. And the author, and I left it here because the author talks about it, but I disagree with the author. No insurance means no access to healthcare. I don't agree with that. You can still get care if you don't have insurance, if you don't have any type of coverage. There's still ways to get care. I am not saying that you get the best of care. Definitely not. I am definitely not saying that. But you can get some care. Another interesting issue, and again, one that I disagree. I disagree because I don't think the author goes deep enough. But the medical outcomes in the U.S., the quality of the care in the U.S. is poor compared to other countries. And I disagree with the author. I disagree the way the author explains it. I think the quality of our care is second to none. I think the quality of care is actually the best in the world. The amount and the quality, I think, is by far the best in the world. And there are many ways of proving that. But it is true that our population is sicker, is far sicker than many other populations where they spend less. But I don't think that's because of the quality or the amount of money. We definitely spend a lot of money and we have the best quality. But there are other reasons why Americans are so sick. One way of looking at this is to use indicators to evaluate our system. And we're definitely going to talk about what these indicators are and how to use them. But very quickly and briefly, right? Here's some of these. This is a simple indicator, which is the life expectancy, and actually we have three here, right? We have the life expectancy, the infant mortality, and the percentage spending based on the GDP, or the the per capita spending, which would be the amount spent divided by the people in the country. Either way, those two are very similar. But what we see here, which is what I'm trying to get to, is the fact that Americans, you can see that right here at the very bottom, right? Americans have, yes, a very high life expectancy, but it's not the highest. The Swiss, look at in Japan, they have a much higher life expectancy, even though they spend a lot less. I mean, look at this. We spend 17.6% of our GDP. And remember how big our GDP is, by the way. $8,233 per capita. But look at Japan. They spend $3,000 per capita, which is 9.5% of their GDP, and they live longer. Yes, that is true. They live longer. They have better health. But I don't think it's because of the quality, as I mentioned before. I think it's because of the lifestyles of the people we're talking about. And with that, that's a very long conversation there, but it's not just the lifestyle, right? It's the education, the wealth, the upbringing, the everything, the culture, all of those things. Americans are very risky and sick people. Americans, we do a lot of stupid things. We don't take care of ourselves, And we know that. We know about obesity rates. We know we have the highest obesity rate around the world, even though ours seem to be improving now, while every other country in the world is catching on and catching up to us. Let's see where that goes. And I've seen that when I travel, I can see that. Over the years, it's very clear to me. But again, the author is trying to focus on this idea that the spending is not bringing the quality, and I disagree. I think it's the lifestyles that is driving this. What do you think? And then, of course, you can't help start picking the data, cherry picking, right? You start picking the little things like, oh, look at this and look at that, right? But for example, look at Germany in the United States. One has a private system, well, a semi-private system. The other one has a completely universal single-payer system. That is Germany, of course. But they both show very similar death rates, right? Look at Germany, 811. United States is 822. That's mighty close. So here's these are two systems that are completely different, and they yield completely different results. But let's see, who's this? Canada, right? Canada has a pretty public, I believe is almost 100% public system. If I remember correctly, it's 100% public, 99.9%. How about that? And that is actually fairly low. That's much lower than the United States and Germany. So why is that? I think it's lifestyles. I go back to the same thing. It's the lifestyles, it's the type of people in your country. It also has to do with immigration. A nation that brings a lot of that receives a lot of immigrants, it's also bringing whatever the conditions of these immigrants are bringing, whatever their diseases, if they're sick, if they have certain issues, that we get as well, right? When we do get their labor, we enjoy their labor when they come in, but we also get whatever they're bringing, and that's definitely going to affect us. You don't have, in countries where you don't have immigration, you don't have that problem. No, people are not bringing in new conditions and issues. And as I mentioned before, obesity which is a lifestyle factor, is at the very top of our list of issues in this country. Is a driver, is a huge driver. It drives everything else, and so we have the highest obesity rates. So clearly, we're going to have the highest, or some of the highest levels in all of the other things that come from having a high obesity rate. So, Adam Smith was the father. Adam Smith, we consider Adam Smith to be the father of economics. He was the one that wrote the first book in economics, which was The Welfare of Nations, which I absolutely invite you to read if you ever have a chance, because it's incredible. It was written in the 1700s. I'm talking to you and I can see my copy right over there. I always have it close by. But I'm on many great things in that book. But one of them is this idea of the invisible hand. And I'm sure you've heard this concept before. But basically, the way Adam Smith described the markets, the perfectly competitive, healthy markets, is as if an invisible hand drives the agents in the market, and this invisible hand makes the agents do what is best for them. It's a self-serving behavior, right? Everyone in the market does whatever is best for them. However, this is what Adam Smith observed, this invisible hand concept, right? When people do what's best for them, they end up doing what is best for everyone. So the total welfare is increased when we all take care of ourselves. So what does that mean? It means that you, I'm talking about you, my students, you are now getting a degree in healthcare, in whatever the ultimate degree is, right? You're doing this for yourself. Maybe some of you are now like, no, I'm doing it because, okay, sure. But let's just say that you're doing it for yourself, right? You're doing it for yourself. Why? Because you want to, because you want to make you want to achieve a higher, pay rate, whatever. But you're doing it for yourself. But ultimately, when you do that for yourself, you're doing something for me, right? Because I need you to get that degree so you can go on, become a professional. You're a professional, but get even better at your job, so someday I'll be able to use you to take care of me, right? And that's how it works. The grocery stores, right? They sell produce because they want to make money, but I have to thank them. Right? I have to thank that type of behavior, because thanks to them, I don't have to wake up every day at 3 o'clock in the morning and go to the fields and pick up my own vegetables and milk the cow to make my put in my cereal and all of that. That's what we're talking about. And even though we're using economics, this is something that most people don't understand. Again, this is usually people that read something about economics and all of a sudden they think they're an economist. They think market failure represents a failure of economics. Like if there's a market failure, well, that proves that economics does not work. No, market failures are a field of economics. Economics studies market failures. We try to figure out why did that happen, and we come up with models and theories and everything that we talked about. And well, in all honesty, market failures are far more interesting and interesting to research than anything else in economics, right? Because they're very intriguing to me. So what is a market failure? Well, this is when, for whatever reason, the market forces fail to yield an outcome that is desirable by all the players, by all the agents. That is below, or maybe it's below what we were expecting or we're hoping, but it's definitely not the highest welfare level that we could have or that we predicted, that we expected based on pure analysis. And in healthcare, this happens very, very often. We sometimes don't see what we expected. And where do this market, what causes these market failures? And there are many types. We'll look at them. What causes them? Well, we've seen some of them already. When a buyer or a seller has too much power, that could yield a market failure. A monopoly, it's a market failure, right? Because all of a sudden we now don't have as much quantity and low prices, low prices. We now have a higher price and a lower quantity. So that will be a market failure. And there's so many more. There are market failures in both the consumption and the production. We have the externalities. Sometimes there are certain things that affect the market that you don't see right away, but they're affecting your market. And that causes a failure in the final output. And you wonder, like, how is this possible? What happened here? Well, it's because there's an externality. Something in the outside is causing your market not to be efficient. We're going to look at those for sure. Especially externalities are actually huge in the healthcare markets. We're going to look at those. I guess I already talked about this. This is the case of a monopoly that sets the quantity where marginal revenue equals marginal cost, and then they set the price based on that quantity. And the final quantity in this case will be Q1. It's much lower than QO. So society welfare is lower. This is a failure. And the same thing with the. Oh, I'm sorry. I thought I was going to talk about something else. Sorry. So what happens? What happens if we have a monopoly? Are we done? Is there anything we can do? Yeah, you can regulate. You can do something about the monopoly and stop it from happening. You can just break it down. There are many cases when the governments just break it apart, right? They divide the company into 2 or 3 or whatever happens, and it's done. Government can do it. But there are other ways. But there's one particular situation that makes it a little more difficult or more complicated. We have something called natural monopolies. A natural monopoly is a monopoly that it just exists due to the fact that the production of that good is so expensive, is so complicated, the initial costs are so high that it makes sense that only one supplier exists. If you have two suppliers, they will not realize the economies of scale, they will have high cost, and they won't be able to supply, and both will go out of business. Only one could supply the good. For example, utilities. And if you're like, wait a second, yeah, because today we now see that these natural monopolies are going away. But that's a different story. But especially back in the day, and still today up to a point, utilities are natural monopolies, because you can't have like 50 companies wiring your city for natural gas and for electricity. You only have one. And yes, there are now different models where there's like two and there's like this thing and the other thing, but let's just keep it simple. Only one can supply it. So what? You're gonna let them just build their grid and build the network of pipes and wires, whatever that is, and then they can behave like a monopoly, charging the margin where marginal cost equals marginal revenue, and just walk away? No. The government can do something about that. The government can impose maximum prices and force the monopoly, the natural monopoly, to charge those prices. The government could investigate and find out that because the average cost curve is downward sloping, right? It's downward sloping. That keeps going down and down and down and down. The government could force the utility company to provide the services, the natural monopoly, to provide the services or sell the good, where the average cost equals the demand curve, which is more in line with the typical behavior of a competitive market. Go back to the competitive market and look at where we had that average cost, the average cost curve. I'm having an issue with that. It's right there where the marginal revenue equals the marginal cost. That's where the average cost, the curve, hits it right at the very bottom. Well, we're trying to kind of mimic that. So what the government's saying is like, look, you'll have to charge an amount that is equal to your where the average cost curve hits the demand curve. And at that point, which will be Q1, P1, that's the price and that's the quantity that you will be allowed to operate. And as you can see, that will be a much lower price and a much higher quantity.